Bismillahirrahmanirrahim. I'm talking about a technology that improved what I would call crossing profile and comprehensive, what we call over-expanding limits. It has a specific long dual Z connector that makes it easier to happen. Of course, the differences between sizes of the stents that we usually use and that of Supraflex is to be not to be overemphasized because it has largest cell area, highest perimeters, and highest side branch expansions. In a vitro study, you can see that the power needed to improve, to advance a Supraflex compared to the all known stent that we have was much lower, and this is a published data. I will talk about what happened in TCT 2025, the randomized, controlled, and registry that included this technology. A comparison between Supraflex and Xience in all-comer population in talent study has shown clearly that over the years 1, 2, and 3, there was numerically, practically superiority, although it is not significant, yet numerically higher with Xience event rates than it is with Supraflex. And also the lower target lesion revascularization needs was also 23% achieved at 1 year in a study comparing both strut sizes, which is basically Supraflex compared to Ultimaster, where 60 versus 80 microns were compared with the program of depth versus sept versus no apt was gradually changed from first to 6 months and 12 months. And that came up with the fact that numerically lower stent thrombosis, TLR, BARC, and TIMI measure bleeding rates were numerically better with Supraflex. Again, for the stent thrombosis at 1 year in a high bleeding risk population, in a sub-study looking at older patients of 75 years and more having MI, etc., again, compared to other stents, the likelihood of stent thrombosis was lower in Supraflex. In a rate of stent thrombosis at follow-up of 3 years, as in FIRE trial, the complete versus culprit lesion vascular entertainment and revascularization, clearly no difference in outcome first, second, and third year. In a 30-day depth in high bleeding risk patients for 1 month versus longer depth, data also showed no difference between whether it is less than 1 month or more than 1 month for stent thrombosis. In this study derived from 3 other studies, FIRE, Cruz, and COMPARE 6080, where high bleeding risk patients were taken away and studied using short depth versus long depth, and looked at the differences, and again similar outcome were shown when Cruz high bleeding risk was compared to FIRE and Earth high bleeding risk also at 1 year. Now these are the total number of patients studied at TCT 25 presentations and included different sites in Europe, Asia, and total more than 200 sites, and numbers of RCTs and registries were included. In a diabetic population with multi-vessel disease, the study aimed at comparing Supraflex with Xience for target lesion failure and safety efficacy. And in this, Tuxedo versus what we call historical control, Tuxedo 2, that randomized Supraflex versus Xience, looked at the primary objective outcome of the target lesion failure as opposed to secondary outcomes of that of MACE, and the tertiary outcome of that of prasugrel versus ticagrelor distribution. Again, the endpoints of ischemia-driven target lesion, cardiac death, target vessel myocardial infarction also were non-inferior using Supraflex compared to Xience for target lesion failure or comparable safety and efficacy findings. For the 3-vessel coronary artery disease, in this population, de novo 3-vessel disease patients were followed by syntax scoring 1 or 2, and used the different technologies to support the procedures, comparing Supraflex versus Synergy, and looked at what we call oriented outcome events comparing the two different technologies or two different approaches, syntax scoring as opposed to SKY approaching, it turned out that the higher likelihood of being a high complex rate syntax score was more likely to show numerically better or at least non-inferior findings with Supraflex compared to Synergy. And of course, if you see at the overall SKY approach, where patients were studied by a heart team and targeted functionally significant lesions, and CTO experts were doing all they needed, again, non-inferiority was also achieved. But if you look at the syntax scoring rates, whether it is low, intermediate, or high and above, again, clearly the higher syntax scored patients did fairly better and resulted in a non-inferiority of Supraflex compared to Synergy. For in conclusion, in a 3-vessel disease patient using state-of-the-art PCI, again, Supraflex was non-inferior to Synergy. The SKY criteria that were used, although associated with PPMI, peri-procedural MI and rate of composite endpoints. However, syntax scoring, especially the higher complexity group, Supraflex numerically was superior to Synergy. The aged population itself was also studied, and if you compare what you call the overall all-comers and Cruz senior, again, there was no difference in target lesion revascularization. However, in aged over, like in 80s and 90s years of age, there should always be a difference, which is a higher likelihood of having cardiovascular death because of advanced age. Otherwise, all other parameters were comparable. In conclusion, largest prospective PCI cohort in the elderly using Suprax Cruz platform has shown safety, has shown excellent technical performance, a strong safety profile, particularly in the aged groups, and marked improvement in quality of life. I'll finish with a case report about a patient had had chest pain and only for 3 to 4 days with known all multiple risk factors with normal otherwise findings. And you will see that his right coronary artery has a middle segment significant lesion and an RPDA of mild lesion that was planned for intervention. However, when I looked at the circ, I found it normal. The LAD was suspicious. Again, here, the LAD definitely suspicious. We had to see it again. And here we see that the LAD most problem was more distally at the bifurcation with the second diagonal branch, clearly showing a bifurcational lesion of certain complexities. And the LAD is rather smaller than it is for the diagonal. And the moment I touched the LAD, with a pre-dilatation, the moment it resulted in worsening of the osteum of the diagonal branch, which is more important than the diagonal LAD itself. Here I decided to start pre-dilating. Both vessels, of course, were started with the diagonal and then to the LAD, only to have a ping-pong effect of the D2 reclosure each time I dilated the one against the other, with a relatively slow flow, worsening with D2 repeated pre-dilatations, and again we're having to fall into this trouble where again flow is remitted rather than improving. So with that, I had to continue with nitroglycerin repetitions. I don't know why this is happening. Anyway, each time with some improvement, but not completely. Eventually, I had to decide to put a stent in the diagonal branch, knowing that even with the 2 wires, there were difficulty of advancing some balloons. However, the stent was advanced successfully, and I decided to do it without a balloon across the LAD at that time. And positioning was supposed to be proper, and post-dilatation, especially the fact that the calcification in the middle of the diagonal was clearly showing issues to be fixed, and post-dilatations instant were done eventually only to develop again spastic responses with D2 wiring wrongly advanced into a branch distally. If you notice it, it will be shown the next image. It's not moving. frozen. You think we can move it? Can we make it? I need only 3 more slides here. Technical help. Simply ping pong effect. I couldn't really get out of it because of of course, the patient at that time was having chest pain and slow flow, responding partially to nitroglycerin. Where are we now? Repeated. Yeah, we're above here. Anyway, this is when the worsening of D2 happened, and then I post-dilated. Then I decided to put a stent, even without having a support from the LAD. Usually I put a balloon to make sure that the stent positioning is proper. I did my best, and then I put my stent 2 to 4 by 24 stent, Supraflex stent, clearly positioned properly, post-dilated, only to develop again spastic reactions and to discover that the distal wire is not really in the main vessel and the stent edge is actually practically almost in the branch. And this is clearly seen here. Then I had to rewire the distal diagonal, and successfully did so, repositioned the edge of the stent by ballooning and treated it with a drug-coated balloon, only to develop that spasm also occurred again into the LAD with worsening outcome. And here again, I had to put a stent, and the stent was positioned properly, and post-dilated, and recrossing into D2, and continuing, only to discover that I have a big chunk of calcium at this ostium of the diagonal, where I had to treat, and I treated it with drug-coated balloon. And you can see that this is where I think the problem had happened. The stent displaced itself by about 1 to 2 millimeters away from the ostium. It managed with the drug-coated. And also I went to the edge of the distal edge of the stent and treated it with a drug-coated balloon. And eventually I finalized the case with the kissing of both. And again, spasm developed. Again, I had to do something. But eventually I found that all segments are treated. And I found this result suitable not to manipulate anymore, because if I do, I will end up with yet the 5th or 6th spastic responses. Here I then treated the RCA with direct stenting, basically showing post-implantation improvements and optimization. And I think basically what happened, this is a stent that helped me do a complex procedure without major problems, with outcome benefits. Patient actually did well after this discharge and went home just 2 weeks ago. This whole thing had happened. Thank you very much.